Hello viewers, this is Dr. Rajiv. Welcome to your education channel YouTube Surgery and Orthopedic Education. Please consider subscribing to it and sharing it with your near and dears to help them prepare not only for the MBBS course but also for other postgraduate and medical job entrance examinations. Please don't forget to hit the bell icon below so that you never miss useful lectures from us. In this lecture, I will be discussing 10 MCQs on a very important and exam productive topic, liver. Caroli's disease is a rare congenital dilatation of the large intrahepatic bile ducts, separated by segments of normal or stenotic ducts. The extrahepatic biliary system is not affected. Pathologically, Caroli's disease results from the arrest of the normal embryologic remodeling of the duct plate, which is the precursor of the intrahepatic bile ducts. This leads to the formation of cystic dilatations in the bile ducts, which can become filled with inaspiciated bile and lead to complications such as intrahepatic biliary lakes containing stones, recurrent cholangitis, and portal hypertension. Jaundice, right upper abdominal pain, fever, also together known as Charcot's triad, are clinical features due to associated complications of hepatolithiasis or bacterial cholangitis. Caroli's disease is transmitted as an autosomal recessive trait. About 50% of cases of Caroli's disease are associated with congenital hepatic fibrosis. When associated with congenital hepatic fibrosis, the condition is known as Caroli's syndrome. Both conditions are part of the spectrum of fibropolycystic liver diseases. Ultrasound and CT scanning are usually diagnostic. Malignant transformation into cholangiocarcinoma may occur in long-standing cases. Hepatic resection is feasible in limited disease. Diffuse involvement and concomitant hepatic fibrosis need liver transplantation. Recurrence is common and long-term surveillance is required. The balloon of the Sengstaken Blackamoor tube may be used to provide temporary hemostasis in bleeding due to esophageal or gastric varices as a last resort when sclerotherapy and banding fail. Sengstaken Blackamoor tube may also be used to arrest bleeding from a penetrating liver injury hole. The gastric balloon is inflated with 300 ml of air and placed over the varices at the esophagogastric junction. Then the esophageal balloon is inflated to a pressure of 40 mm Hg. Gastric and esophageal aspiration are done through two other channels. The position of the tube is confirmed by X-ray. The balloons are temporarily deflated after 12 hours to prevent pressure necrosis. Aspiration pneumonia and esophageal ulceration or even perforation are serious complications. Balloon tamponade is a very effective temporary measure in stopping bleeding, and a more definitive treatment can be carried out after the patient becomes stable. Bleeding from esophageal varices is a serious condition. It requires prompt medical treatment or endoscopy or both. The drugs commonly used to control bleeding from esophageal varices are vasopressin, octreotide, beta blockers, and sclerosing agents. Vasopressin constricts blood vessels through V1 receptors and increases peripheral resistance. It often stops bleeding by constricting mesenteric blood vessels and reducing blood flow through the liver to the varices, allowing clot formation and arrest of bleeding. Octreotide is a synthetic somatostatin analog. It reduces hepatic blood flow and helps stop esophageal variceal bleeding by decreasing pressure in the varices. Beta blockers such as propranolol and nadolol are used to lower blood pressure in the portal vein, reducing the risk of bleeding from varices. Sclerosing agents such as ethanolamine oleate is injected directly into the varices to cause them to shrink and stop bleeding. In Budd-Chiari syndrome or hepatic vein thrombosis, there is obstruction of hepatic venous outflow due to total occlusion of hepatic vein by a blood clot or a venous wave. In this condition, there is selective rise in capillary pressure in the portal venous system. This condition typically affects young females. Sudden occlusion of hepatic veins may cause acute fulminant liver failure, but in most cases, abdominal discomfort, jaundice, hepatomegaly, and ascites are the main presenting complaints. In chronic cases, liver congestion leads to the development of impaired liver function, cirrhosis, portal hypertension, ascites, and esophageal varices. The cause may be an underlying myeloproliferative disorder or procoagulant state such as antithrombin 3, protein C, or protein S deficiency. It can also occur due to extrinsic compression. A coagulopathy workup and CT imaging to look for masses should be done in suspected cases. In established cases, the CT scanning shows a large congested liver or a small cirrhotic liver in which there is gross enlargement of segment 1 or the caudate lobe. Treatment is liver transplantation in patients presenting with established cirrhosis or complications of portal hypertension or fulminant liver failure. In pre-cirrhosis cases, portosystemic stenting by tips should be considered. Patients usually need lifelong anticoagulation after operation. In most patients, the etiology of a pyogenic liver abscess is unexplained. Common associations are bile stone disease and ascending portal vein infection or pyelophlebitis. The latter is usually associated with conditions of intra-abdominal sepsis such as appendicitis, diverticulitis, pancreatitis, inflammatory bowel disease, pelvic inflammatory disease, perforated viscus, and omphalitis in the newborn. Penetrating and blunt trauma resulting in an intrahepatic hematoma or an area of liver necrosis may also subsequently develop into an abscess. The most common pathogens isolated from liver abscess pus are Streptococcus miliary, Escherichia coli, and Klebsiella pneumoniae. Most hepatic abscesses are reported in the right hemiliver, accounting for about 75% of cases. In the options, the Streptococcus miliary is not mentioned, hence, the most appropriate answer will be option A, the E. coli. Diagnosing pyogenic liver abscess involves a combination of clinical features, blood cultures, and imaging studies. Patients typically present with non-specific constitutional symptoms like fever, chills and jaundice. Right upper quadrant abdominal pain and tenderness. The most common underlying condition in people with pyogenic liver abscess is biliary tract disease. Non-specific abnormalities of blood tests like leukocytosis and anemia are common. Liver function test results are only mildly deranged. The alkaline phosphatase level is mildly elevated. There is no specific serological test available to help. Plain abdominal radiographs are rarely helpful. Ultrasound and CT are the mainstay diagnostic modalities for pyogenic liver abscess. Hepatocellular carcinoma is one of the fastest growing cause of cancer worldwide. Main interventions to improve hepatocellular carcinoma treatment outcomes are early detection of HCC and treating the cause of the underlying liver disease. A screening for hepatocellular carcinoma in patients with chronic liver disease is crucial for early detection and improved outcomes. This is because there are no clinical features early in the disease course specific to hepatocellular carcinoma. Symptomatic disease is often locally or distally advanced with few therapeutic options, and these have limited efficacy. Because the principal risk factors for hepatocellular carcinoma are cirrhosis and hepatitis B and C, a screening should target patients with these conditions. The most common and most cost-effective screening methods are serial ultrasound and serum alpha-fetoprotein testing. A screening is typically recommended every 6 months. Early detection through regular screening can lead to better outcomes, including the possibility of curative treatments. Biliary cyst adenocarcinoma is an extremely rare malignant neoplasm that originates from the bile ducts. It is considered the malignant counterpart of biliary cyst adenoma. These tumors are typically found within the liver and are more common in women older than 40 years. Its symptoms are often non-specific and can include abdominal pain, distension, and a palpable mass. MRI and CT scans are useful for diagnosis. Biliary cyst adenocarcinoma is usually asymptomatic until it grows very large. Suspicious cases are diagnosed with the help of CT scan or MRI together with elevated serum CA19-9 levels. Treatment is complete excision by a major liver resection with clear margins. The prognosis is generally better than for other malignant liver tumors. Dilated CVD and raised serum bilirubin suggest the diagnosis of obstructive jaundice, whereas elevated alkaline phosphatase and GGT together with raised serum bilirubin suggest cholestatic disease. In both conditions, the preferred first-line investigation should be magnetic resonance cholangiopancreatography, that is MRCP, because of its excellent diagnostic performance and non-invasiveness. Ultrasonography should be used as an initial screening modality for predicting the level and nature of obstruction in patients with a clinical suspicion of obstructive jaundice. Alkaline phosphatase and gamma-glutamyltransferase (GGT) levels typically rise to several times the normal level after several days of bile duct obstruction or intrahepatic cholestasis. The elevation of GGT alone with no other liver function test abnormalities often results from enzyme induction by alcohol in alcoholism in absence of liver disease. The GGT value and the alpha-fetoprotein level can become mildly elevated in patients who are on phenytoin, phenobarbital, and other aromatic drugs. Fever and tachycardia after laparoscopic cholecystectomy should prompt getting an ultrasound done to look for the region, and if a collection is noted in the subphrenic or subhepatic region, this should further be investigated with an MRCP to find the site of a possible bile leak. Now you need two actions to take. First is to control and ameliorate the acute symptoms, followed by managing the bile leak. For symptom control, the collection may be drained under ultrasound guidance using a pigtail catheter. Then, with the help of ERCP, a stent may be passed across the leak site in CBD. Thank you so much for watching. Please subscribe and stay tuned for more educational videos.